Thank you for joining today's presentation. My name is Dr. Jackson Lau, and I'm the Senior Manager of Professional Relations at Euclid Vision Corporation. I'm also a practicing optometrist near San Francisco and continue to teach fourth-year optometry students who rotate through our clinic. Before I begin, I want to thank the GelFlex team for inviting me to speak to you about this topic. If there are any questions, please feel free to ask them through the Q&A box. Today, I'll be discussing the importance of corneal topography in orthokeratology fitting. We'll begin by discussing the benefits of myopia management using Euclid Ortho-K. Our focus will be on how to utilize corneal topography in optimizing your Ortho-K fits. And through an in-depth case review, I'll share some important tips on patient selection and troubleshooting strategies. For those who are not familiar with Euclid, our company is over 25 years old with a sole focus on myopia. Euclid is one of the most trusted Ortho-K brands for both clinical research and practice globally, as we are one of the world's most studied lenses on myopia. Our consultation team and customer service are our strengths, and we optimize our lenses to be able to manage a wide range of corneal shapes and parameters, and our R&D team is rapidly growing as we continue to work on new designs and materials. As we can see with these alarming statistics, high myopia significantly increases the risk of more serious eye diseases compared to emmetropes. A 6-diopter myope is almost 850 times more likely to develop myopic macular degeneration, over 12 times more likely to develop retinal detachments, and almost 3 times more likely to develop open-angle glaucoma. Simply reducing the rates of myopia progression can have a significant positive impact on your patients. Euclid's design philosophy is based on the concept of simple fitting but complex designs. The simple fitting means that with just 3 parameters, Ks, Rx, and horizontal visible iris diameter, we'll be able to design a lens that will be successful 87% of the time on the first try. For novice or beginning fitters, this will allow you to have a great fitting lens without much input. However, as you mature and become more proficient with fitting, the complex design allows the practitioner to make almost any adjustment to your patient's needs, whether it's the diameter, optic zone size, reverse curve, alignment curve. All these can be adjusted with a high level of precision. Euclid is proud to be trusted as one of the most researched Ortho-K lenses in the world. There are over 100 peer-reviewed publications worldwide using Euclid lenses, and around 50 of those specifically studying the effects of slowing axial elongation. There's one such study in the US, which was a 3-year retrospective review on multiple sites where independent ODs chose to use Euclid lenses 84% of the time. They found that almost 70 to 80% of children experienced minimal refractive error and axial elongation over those 3 years. In addition, the cumulative absolute reduction in axial elongation, also known as the CARE value, was about 0.32 millimeters over 3 years, which is a great consistent result with other prospective studies. Euclid Max offers all the material properties that you would want in an overnight Ortho-K design. You have the same great 87% first fit success. You have great wettability without the need for any additional coatings or plasma. And at 180, it offers one of the highest DK materials approved for overnight Ortho-K wear. It's optimized to resist warpage, scratches, and chips. Despite the ease of using Euclid designs, it is highly critical that practitioners not only invest in topography instrumentation, but invest their time in learning how to analyze topographical patterns carefully so that you can help those patients with more complex eyes. Sometimes even easy cases can become complex if you don't know what to look for. I want to begin by sharing some classic Ortho-K topo patterns that you'll run into. In most cases, your first lens will likely be your last, and you may be getting a perfectly textbook bullseye pattern. Starting from the middle, you have your optic zone or base curve area, and this correlates to this central flattening as shown in this treatment zone. Though it looks like corneal touch, as shown in this video, properly fit Ortho-K lenses should technically have a small amount of clearance between the back surface of the lens and the cornea, but is simply not visible when the clearance is below the human visible threshold of 20 microns. Next, we have our reverse curve, which is named after the reverse geometry nature of this steeper curve. And allows for the creation of this tear reservoir that is critical for this mid-peripheral steepening of the cornea, as indicated by this red ring. Then we have our two outer alignment curves. And these are shown by this dark band of corneal alignment. Ideally, you want to see this 360 degrees all the way around. Lastly, we have our outermost peripheral curve. And this is sometimes called edge lift, which provides for tear exchange and lens movement. Now let's review some of the more common issues you may encounter. Lateral desensation is particularly common, especially when you don't have a large enough lens diameter. You will see these crescent-shaped patterns either nasally or temporally on the topography. And to resolve this, you would need to increase the lens diameter typically. These images highlight the importance of choosing a proper lens diameter. Many manufacturers and practitioners are moving towards fitting lenses around 90 to 95% of the HVID. On the left here, we have the smallest diameter showing a bit more movement after the blink and will most likely lead to decentration. And in contrast, the rightmost image is of a lens that is too large, where it's crossing the limbus. This lens is likely very stable and moves minimally. But ideally, you'd want to design a lens that is somewhere in the middle where the diameter is just slightly smaller than the HVID. When Ortho-K lenses have excessive sagittal depth or height, you may encounter a few different types of corneal issues and topography patterns. Note how the central optic zone area is not quite as defined as it transitions to the reverse curve. It has this feathery appearance due to that excessive sagittal height. And as we progress and increase towards more sagittal height for the lens, it becomes even less defined and can even lead to these large insertion bubbles. And in extreme cases, it may require the ECP to manipulate the lens and the eyelid to get fluorescein underneath the lens, almost like a scleral lens. A common issue from excessive lens sagittal height is undertreatment and the appearance of these small focal areas of steepening called central islands. These patients may not achieve optimal vision and would benefit from a flattening of the reverse curves to reduce the lens sagittal height. Be careful, though, to always monitor the cornea carefully because there's central staining associated with the central island. You may actually be dealing with a false island, which is actually due to the opposite mechanism. And that's when there's insufficient sag causing mechanical rubbing of the back surface of the lens on the cornea. And in these situations, you will actually make the problem worse if you mistakenly reduce the sag height further. So always check the cornea, and if there is persistent staining centrally, you may actually need to increase the lens sagittal height despite having central islands on the topographies. Brownie faces are caused by inferiorly decentered lenses. The lens has too much sagittal height, so we need to, again, reduce that by flattening the alignment curves. Double ring patterns may be seen on topography from excessive sagittal height. They may also be caused by a poor insertion technique, so I always guide the patient to insert the lenses face down with an insertion drop so the liquid is retained, and then ask the patient to go to bed immediately instead of reading in bed. Oftentimes, if the vision is acceptable and there's no corneal compromise, double ring patterns on topographies may actually be monitored and require no changes. However, if there are issues, this can be resolved by reducing the lens sagittal height. Lens binding is the last of the common troubleshooting issues with excessive lens sagittal height. It can cause these ring-like imprints on the cornea and is associated with staining. Classically, the topography pattern can show this focal area of steepening. And as with the other examples, the fix is to reduce the lens sagittal height, whether through the reverse curves or the alignment curves. In the opposite scenario, with insufficient lens sagittal height, we would see sodium fluorescein patterns and topography patterns such as these. Too little sagittal height will cause the lens to ride high and superiorly, leading to smiley face patterns. We can see the fluorescein pooling or leaking in these alignment curve areas, rather than our desired 360-degree band of lens alignment or seal-off. To resolve, we would increase the lens sagittal height 360 degrees, since it appears that the alignment curves are a little bit too flat in both meridians. This example is of a highly width the rule cornea and a lens that already has a moderate amount of lens toricity. Still, in this vertical meridian, it appears that we have some fluorescein leakage and incomplete seal. So if you see this type of appearance, you may need to either add or increase lens toricity. However, keep in mind that many patients can have acceptable fits, even if you don't have a perfect red ring 360 degrees. And what we see here on this right is common in many toric corneas. As we stated earlier, a common issue with insufficient sagittal height is central staining. This can be seen more frequently early on in Ortho-K treatment, particularly in higher myopes. And if it's just a mild amount, it tends to resolve on its own with just an increase in lubrication and additional time. However, if this is unresolved or a significant amount of staining is present, then we would need to address it by increasing the lens sagittal height. One of the great things with using Euclid is having the option to create patient-specific designs. Based on recent scientific literature, the smallest optic zone sizes may show a slight increase in efficacy for slowing axial elongation. However, in my experience, there can often be significant compromise to a patient's vision due to the excessive aberrations when the optic zone is too small. But by allowing you as the practitioner to fully modify the lenses, you can be in full control of their treatment. We can see the treatment zone sizes on the topographical maps changing as we increase the optic zone sizes. For most young patients where you are managing their myopia progression, the middle range optic zones are recommended to balance for their visual performance. And for adult patients, using the largest optic zones can cut down on their higher order aberrations and make them much more successful. Now, to showcase the importance of corneal topography when fitting Ortho-K, we're going to jump right into a fairly technical case review. While 87% of the time your properly selected patients will have a first fit success through our empirical ordering process, fine-tuning your topography skills will allow you to effectively troubleshoot that remaining 13% who may not be immediately successful or perfect Ortho-K candidates. This complex case should be an exception, but will provide many areas of discussion for how to take proper topographies, as well as how to utilize this technology to enhance our Ortho-K fits. Patient SL is a 13-year-old Asian female, and here are her baseline parameters. She's a low to moderate myope with pretty average K values and slightly smaller than average HVIDs. Her axial length is also fairly normal, but she has a history of myopia progression over the past few years. One thing to note is that her spectacle and corneal cylinder has a slight mismatch. And also note that her entering best corrected vision with her spectacles is mildly reduced at around 20/25. Our discussion today will be focused on the Medmont topographer, though many other brands will also have equivalent tools to help you be successful. I just find the Medmont to be particularly powerful when managing patients with Ortho-K and other specialty contact lenses. The first general rule of thumb when acquiring topographies is whether or not it's your staff or you taking the scans, is to ensure that you take multiple scans. For baseline maps, I recommend taking at least 3 to 4 scans so that you can choose the maps with best consistency. In this example, you can see that the color map does not extend fully in the vertical meridian, likely due to the patient having a smaller aperture size, which makes sense given that she's a young Asian female. Notice that some of the superior lashes prevent the full collection of corneal data. And after multiple attempts, this was the best the doctor could do with the patient. So ideally, we would like to be able to capture even more of the superior cornea. Next, we want to assess the contour and the colors of the map. And we want these smooth transitions and rounded rings. If you see very abrupt color changes, then consider repeating the topography or applying a drop of artificial tears prior to repeating it. And depending on the manufacturer, you may also have the ability to acquire composite maps and be able to stitch together images from different fields of gaze, though that was not done on this patient. Lastly, it's often very helpful to compare the keratometry values from other instruments such as the autorefractor to make sure you're in the same ballpark as the topography keratometry values. In this example, we're pretty close. We typically assess baseline maps for Ortho-K using axial displays in order to qualitatively determine the type of corneal astigmatism you're dealing with. That is, whether the astigmatism is localized centrally or extends from limbus to limbus. The axial map tends to average out many of the details and provide an overview of the shape of the eye. I start here whenever I assess the cornea in the beginning stages of Ortho-K treatment, as well as assessing the refractive nature of the cornea. The tangential or instantaneous map provides more detailed information and is used to follow the shape and location of Ortho-K treatment at all follow-up visits. So that means the majority of the time, I am using tangential maps. I also often use tangential displays to help me confirm the centration of my maps. In this example, we can see this blue, flatter peripheral cornea is pretty symmetric on both the nasal and the temporal side. In contrast with this other example, this map shows that it's not quite as centered, and we can see a bit more blue peripheral cornea here temporally than nasally. And the reason for this difference in certain patients is angle kappa, which is the angle formed between the geometric axis of the cornea and visual axis. So for proper centration analysis, it's often recommended to center the maps based on the geometric center of the cornea. Instead of asking the patients to fixate on the center of the target, which will produce a map centered on the visual axis, it may be more appropriate to ask the patient to fixate one or two rings nasally in order to acquire a geometrically centered scan. Adjusting the topography scale is helpful in allowing you to see more details of the cornea. If your scale is too large, you will often lose these critical details. So if your instrument has the ability, you may be able to adjust the scale to preset ranges or even custom ranges. So in this example, the scale currently ranges from about 37 diopters to 46 diopters. In the bottom left corner here, if we were to click that and adjust it to, let's say, increase that scale range to 35 to 50 diopters, we can quickly see that there is a moderate loss of details on the color map. Similar to visual fields, heavy analysis comes from a deep dive on the quantitative values. As a reminder, keratometry values, whether they're real or simulated, are typically measuring the central 2 to 3 millimeters. With any corneal GPs, and Ortho-K is not an exception, it's critical that the corneal cylinder is relatively closely matched to the refractive cylinder in order to achieve the best visual outcomes. Our patient has about a diopter of cylinder mismatch between the spectacle and the cornea. Right around 1 to 1.5 diopters of mismatch is where I start to think that there may be some residual cylinder that may cause less than optimal vision. So let's keep this in mind as we troubleshoot this patient's case. Next, I look at the E values. And as we may be recalling from our schooling days, eccentricity is the flattening from the center of the cornea to the peripheral cornea. And this is critical when designing Ortho-K lenses or troubleshooting. Average E-values are between 0.5 to 0.6. So if you have excessively low E-values, it means there's not much flattening as we reach the peripheral cornea. So we may need to compensate by designing lenses with steeper alignment curves. In the opposite end of the spectrum, higher E-values suggest that there's a greater rate of flattening. And in these situations, we may need to order flatter alignment curves. A relationship has been found between higher E values and higher potential refractive changes that you can induce in Ortho-K. And it's believed this is due to the fact that Ortho-K has a sphericalization effect. So if you have higher E values, you have more room to sphericalize the cornea. Back to our case, there's something interesting to note that their E values here are actually reversed. And the flatter E values should, typically in a width rule cornea should be much higher than the steeper E values. But in this case, it's reversed. A couple reasons. This could be simply due to a topographical error. Second reason, sometimes when you're dealing with very spherical eyes or irregular corneas, the E values may be reversed. But in our example, there's no indication of that. We have a fairly straightforward with the rule cornea. So we would expect E values to be lower in this steep meridian. So we may chalk this up to topographical error, but we want to keep this in mind as we go through the rest of the case. Perhaps we're dealing with an eye that has particularly flat peripheral corneas. Some topographers, including the Medmont, will have additional indices for evaluation. The IS index is the inferior superior index. And since we're typically dealing with normal corneas with Ortho-K, you'd expect this to be in the normal range, which is typically under 1 or 1.5. The IS index is also helpful for me because something around the lines of 90% of corneal thinning disorders present in the inferior hemisphere. So this can help you flag for abnormal eyes where you may not want to perform orthokeratology. The SAI and the SRI, these are surface asymmetry and surface regularity indices, and these analyze the relative smoothness and symmetry of the maps. I find these to be particularly helpful to determine how reliable the maps are from the tear film. And if you get flagged as abnormal, it may indicate that you want to repeat your scans or add a drop of artificial tears before repeating. For this right eye, we can see that our indice values are all in the normal range, indicating a high quality scan, and it's free of any kind of corneal disease. If we were to remove the color map, we can see that the mires are clean and run parallel without any ring jam. Here's a picture of the left topography scan where we see the contours are not quite as smooth. There's some jaggedy edges here, and this may indicate an area of tear film thinning. There's also this flattening centrally, which is a little bit unusual. And so in contrast to the right eye, the left eye is flagged as poor for these surface regularity indices. And that's shown here. If we were to remove the color map, we can see that there's a small amount of ring jam, which likely contributed to those abnormal SRI and SAI values. Here's an extreme example of moderate staining or PEE causing significant ring jam. Many topographers will also have tools to help measure horizontal visible iris diameter. In this example, the patient's HVID was smaller than average at about 10.8. And as we know, eyes with smaller HVIDs have less sagittal height. This may indicate that the lens we design will need reduced sagittal height as we go through the design process. One thing to note is that if your instrument measures what we call white to white, that will often overestimate the HVID, so you may need to compensate accordingly. Corneal elevation is especially important when designing Ortho-K lenses. And in particular, we're looking at the sag height differential between the primary meridians at an 8 millimeter chord. The reason we're looking at the 8 millimeter chord is that Ortho-K alignment curves typically land right at this 8 millimeter distance in the peripheral cornea. If there is greater than 25 to 30 microns of differential between the two meridians, then you'll likely benefit from having an Ortho-K design with toric peripheral curves. In this example, we see that there's an automatic software calculation of this value. However, patients with smaller apertures such as this may cause erroneous values, such as this missing data in the superior quadrant. So in those situations, you may want to consider manual verification. And here we are showing the elevation map where you can individually select points and you can see those elevation data points just with a click of a mouse. This diagram more easily illustrates how this elevation data is generated. It's measuring elevation and depression points relative to a best fit reference sphere. If we look at the vertical meridian in this red line of this with the rule cornea, we can see that there's greater depression relative to the best fit reference sphere. And in contrast, this blue line horizontally shows that it's elevated relative to the reference sphere. So in this right example, what we would do is take the average of the horizontal meridians, which would be about plus 30, and then the average of the vertical meridians, which would be about negative 40. And if that difference is greater than 25 to 30 microns, which it is, then this Ortho-K design would likely require toric peripheries to work properly. There are other tools that you may find in the topography instruments that helps you calculate these elevation data automatically. This is also in the MedMont, and this is an example from the Pentacam. So let's say if you don't have this fancy data and you don't have the elevation data available, is it possible to calculate based on other values that you have? So recent research out of the University of Houston College of Optometry found that there's a correlation between your baseline corneal toricity, which is typically measured within the central 2 to 3 millimeters, and that peripheral elevation difference. And they discovered that each diopter of corneal toricity equated to around 25 microns of elevation difference at that 8 millimeter chord. So this way, I like to start thinking about using a toric Ortho-K lens, usually when I have about a diopter of corneal cylinder, and I like to correlate this to the elevation data if it's available. With these topography basics in mind, let's go back to the case. Here's a reminder of the patient's baseline parameters. And with our empirical ordering process enhanced by the topography data, these are the baseline lens parameters. Most are fairly standard, but given the smaller HBID, we started with a slightly smaller than average diameter at about 10.4 millimeters. And the mild amount of sag height differential, which was between 25 to 30 microns, led us to designing a 1 diopter toric periphery. So this lens was dispensed, and the patient was taught proper insertion and removal techniques successfully, and they were able to take the lenses home. They returned the next morning for the 1-day follow-up. And the patient reported being able to properly insert and remove the lenses within about 10 minutes. Though patients are often being asked to come in wearing their lenses only on the 1-day follow-up, this patient had removed the lenses prior to the appointment. She did note that there was a little bit of asymmetry in her vision between the two eyes, and her left lens in particular was pretty tight on removal. And upon the slit lamp evaluation, we found that there was a bit of a mid-peripheral and peripheral ring-like indentation patterns on the cornea. So given the patient's concern, the significant lens binding, and the asymmetric vision, the doctor decided to reorder a lens immediately. And this brings me to an important tip when managing Ortho-K, which is to only consider early lens modifications when there's a potential for corneal health issues or a manufacturing error. In almost all other instances, we would recommend allowing the patient to wear the lenses between 2 to 4 weeks before making lens modifications. An additional note for lens binding, it's recommended to increase lubrication and ask the patient to manipulate the eyelids or the lens to dislodge it before removal. But in many instances, lens binding can indicate that the lens has excessive sagittal height, and therefore we can resolve the issue by flattening the peripheral curves and the alignment curves. Here are those standard parameters again, and we decided for this left lens to reorder it with 1 step flatter alignment curve and 1 step flatter peripheral curves. Since we are comfortable with the patient as far as, let's say, insertion removal, and they were very cautious in terms of giving us information if anything were to go wrong, we allowed the patient to have the lenses sent directly to their home, and they were asked to start wearing the lenses and come back a couple days or about a week after starting lens wear. In the meantime, if any issues were to arise, they were advised to call the office immediately. So the next follow-up, they had been wearing the original right lens and the new left lens for about a week. And here are the findings from this late 6 p.m. evening appointment. The patient reported improved insertion removal techniques. She's feeling comfortable. Vision was functional, though it was a little blurry at the far distances. And now what she experienced, though, was that the right lens was occasionally hard to remove despite being told to use extra artificial tears and the sort of nudging technique with her finger through the eyelid. So these refractive results are consistent with our expected amount of residual cylinder, given that the patient had that mild amount of mismatch between their spectacle and their corneal cylinder. And again, note that this was a late appointment at 6 p.m. and that the slit lamp findings were clear. Topography scans were captured, and the right eye treatment appeared to be well-centered, but had this sort of classic double ring pattern, which we now know to be caused by excessive sagittal height. The left topography pattern looked great with this well-centered bullseye pattern, this even central treatment zone. Here are the difference maps, which provide a comparison by subtracting the follow-up map from the baseline to see what kind of changes that you've induced onto the cornea. Here's the corresponding difference map for the left eye, which again looks great. Here's where we ask the patient to put the lenses on to assess the fit. And I highly recommend doing this for Ortho-K fitters of all levels, because I know there are some practitioners who only rely on their fitting decisions on topographies, but I still find significant value in matching our slit lamp findings to our topographical data points. Note that the right eye lens is slightly inferiorly decentered with a minimal amount of movement. In order to see this bullseye pattern, it actually required the doctor to gently depress the sclera to allow fluorescein to get underneath the lens. And in contrast, the left lens is centered a bit more superiorly. It has adequate edge lift and slightly more movement. And if we recall, this was the left lens that was immediately reordered with flatter alignment curves and peripheral curves due to the lens binding. So it makes sense that this would center a little bit more properly compared to the right lens. So for the right eye, the combination of the double ring pattern on topography, the patient reporting the tight lens on removal, and the fluorescein pattern requiring a little bit of scleral depression for proper tear exchange. These were all findings that were consistent with a lens that was too tight or excessive sagittal height. So this was all despite the patient doing relatively well at this time. So we suspected that the right lens could still be binding, but due to the fact that this was a late evening appointment, the corneal findings could have been resolved. The patient was asked to continue wearing the lenses and to return in 2 weeks for an earlier morning appointment. At the 3-week follow-up, the patient reported being much more comfortable with insertion removal. She described an overall good comfort and vision again, with mild regression noticed at the end of the day. And mom reported that the patient was getting on average 7 hours of sleep a night. And note that this was again a morning appointment, and that the visual acuity and refractive findings were on par with what we'd expect. But now our suspicions were confirmed that there were signs of lens binding under the slit lamp, with both mid-peripheral and peripheral ring-like indentation patterns. The topography results were consistent to the previous visit. Here are the difference maps again for the right eye, as well as the left eye, which looked consistent to the previous maps. The fluorescein patterns were also looking quite similar to before. However, I do want to bring to your attention the difference between what we saw in the right eye at 1 week versus 3 weeks. This was the same eye, same lens, but given the amount of fluorescein used and how long the videos were recorded after the fluorescein installation, it caused the appearance to look quite different. So keep in mind when you're assessing your own fluorescein patterns, it's important to give all your patients enough time for the fluorescein to settle. Otherwise, you may be confused or tricked by the appearance of the fluorescein pattern. With those corneal findings in the right eye, the right lens was redesigned similar to the left eye. With the initial parameters, we decided to, similar to the left eye, flatten the alignment curve and the peripheral curves 1 step. And this was again sent directly to the patient, and they were asked to return for a follow-up after 1 to 2 weeks of wearing the new lens. By their next visit, she had been wearing the new right lens for about 2 weeks, and it had been about 6 weeks total for the current left lens. The patient at this stage was functioning very well with her Ortho-K treatment. What we found, though, was that her right eye vision was mildly reduced compared to the left eye, which was consistent with some of the refractive findings. There was a difference in the slit lamp findings. What we found was an improvement in the lens binding, as it reduced from a double ring pattern to a single ring pattern with the indentation marks. Nonetheless, there was still an impression ring in the periphery of the cornea. And here are some pictures of that indentation pattern in the right eye, whereas the left eye continued to be clear. Looking at the lenses now, the right lens now appears to be positioned slightly more centrally compared to before, where it was a little bit more inferiorly decentered. Looking at both lenses, they appear to be mildly oval shaped in the optic zone, but the edge lift and movement was adequate. Don't be alarmed with the oval appearance of the optic zones, as that can be commonly seen in toric corneas. The latest topography maps now show that the reduced sagittal height with the right lens helped resolve that previous double ring appearance. And the left eye continues to look great. If we were to compare the treatment maps side by side, you can note that the central treatment zone for this right eye is not quite as even with the color gradation compared to this nice even color for the left eye. And recall that the right eye vision was not quite as sharp as the left eye, corresponding with these refractive values that suggest that we could push the treatment a little further for sharper vision. In addition, the doctor also recently heard about the benefits of smaller optic zones for potentially improved efficacy in slowing eye growth, so a decision was made to modify both lenses. On the top row are the current lens parameters, and the bottom row are the new parameter changes in red. And don't worry, if those changes are a bit overwhelming, let's break down the individual steps, particularly for the right eye. So for the left eye, we simply change the optic zone a little bit smaller for potentially a better effect for slowing axial elongation. For the right eye, to help with the mildly reduced vision and uneven treatment zone, and to push a little bit more of the treatment, we flatten both the base curve by about a half diopter and the reverse curve 1 step to reduce the sagittal height, basically bringing down the roof of the lens so that we can get more even treatment. Again, the optic zone reduction was simply to have additional anti-myopia effects based on the recent scientific literature. And the additional flattening of the alignment curves were to help resolve the apparent lens binding that still persisted with this patient despite the corneal appearance. For the left lens, we simply reduced the optic zone with no other changes. Now, both lenses were again sent directly to the patient, and they were asked to follow up within 1 to 2 weeks after wearing the new set of lenses. At the next follow-up, the patient reported doing very well with the latest lenses with great comfort and vision. The doctor was very happy with the results as we were reaching their maximum potential vision at 20/25. And the patient was slightly hyperopic in the morning time, which is exactly where you want them to be for best visual results. Most importantly, the cornea was completely clear without any indentation marks or corneal compromise. The right eye topography map looked quite a bit more even in the central treatment zone area now, which correlated well to their improved visual acuity. Here's the left eye maps, which continue to do well with the smaller optic zone. So here we have the final finished product, with both maps looking great, centered, even treatment zones, correlating to good vision and normal corneal health. The fit was officially finalized, and the plan was to monitor the patient in 4 to 6 months for axial length changes. I want to emphasize that this was a complex case where there had to be quite a few lens modifications to get to the final fit. While 87% of the time, you'll find a great fitting lens on the first try, this patient was atypical, leading to a great learning case. So what did we learn? Number one, always try to correlate your topography findings with clinical findings. There can be a lot to uncover by critically analyzing your topographies, but it's important to be able to assess the fluorescein patterns effectively as well. This case had quite a few learning pearls, and fortunately, all the lens modifications made sense. But in clinical practice, it doesn't always work out this way. Despite us making multiple revisions to the lens design, we tried not to reorder lenses too quickly unless there were concerns with corneal health. I always teach ECPs who are new to Ortho-K to be confident in dispensing lenses for a few nights if the fluorescein pattern does not look perfect, as you never know how the lens truly interacts with the eye in a closed eye environment. The topography will uncover many things, but when you're ready to troubleshoot, it's best to give it time and make sure that there are repeatable results over separate visits. I like to wait at least 2 to 4 weeks to see consistent findings before I reorder lenses in almost all instances. In retrospective review, there were multiple reasons this was a complex case. The patient had corneal elevation differences that required toric peripheries. The corneal eccentricity, which we may recall as being unusually high, as well as the smaller than average HPID, means this cornea had relatively lower sagittal height and was probably extra flat in the periphery. This is why we had to go so much flatter than our typical standard design. And lastly, I want to emphasize that 20/25 to 20/30 vision and even double ring patterns may have been perfectly acceptable for many patients, especially considering that their best corrected vision with spectacles was around 20/25 already. However, if there are any indications that there can be corneal compromise, then it would be prudent to take the steps to improve the fit, which was the case here with this patient's stubborn lens binding signs. So thank you very much for attending. I want to invite my colleagues to join me right now, and we're going to open this up for questions. Feel free to either ask them through the chat box or the Q&A.
Hey, Jackson, there's a question. It's a great question. Do you always ask the patient to wear lenses in on day one review?
Thanks, David. That is a really good question. So historically, most institutions, most colleges, and most of the seasoned practitioners have asked patients to wear in lenses in that morning appointment. That being said, there has been a slight shift in many practitioners in modern times where we feel as if we may just get as many indications of proper lens wear or corneal health, even if the patient were to remove it for that overnight appointment. So I think it's still, depending on the practitioner's comfort level. Certainly, if you are new to fitting Ortho-K and not that experienced with looking at a lot of corneal findings, at least when I teach my students in my clinic, I still strongly recommend that they see if the patient can come in wearing the lenses. Some of the exceptions may be for adult patients. Adult patients, if they have to drive and they don't have anyone to bring them to clinic, then if it's particularly uncomfortable in the first day or first week, then certainly I think it's reasonable for them to remove the lenses, assuming they can see well enough. But by and large, it's still up to practitioners' preference. But I know there's been a little bit of a shift over time recently.
Here's another question. Do you have a recommended topographer or a preferred topographer?
Yeah, as we went through the case, certainly some of the most common topographers that are being used, at least in the US, and I'm sure in Australia as well, are going to be the Medmont, the Oculus Keratograph, Zeiss Atlas, and a whole host of others. But those are probably the most common brands that are used in terms of what we see from our customer base. That being said, I wouldn't hesitate to send what information you have. I know a lot of practitioners may be just getting started, and the more information, it could never hurt. We could always just choose to ignore the data, but if you can provide that information, that would help, both the teams, whether it's the consultants or anyone that's trying to guide the process for troubleshooting, to do the best possible job for the patient. And just a final point about, topographies, if you are able to, and it's highly, highly, highly recommended to actually export like the data or the raw files from the topographies. There's just so much information, as you guys saw through the presentation. There's just so much information we can extract from the actual raw files, as opposed to a screenshot from your phone or just a picture. While that is better than nothing, it's just certainly a lot more useful if we're able to extract the data files. And both the teams in the US and at GelFlex, if you are not too familiar with how to do that, we can provide you informational sort of handouts or PDFs on how to actually do that. It's not particularly difficult. It's just a couple extra clicks, but that'll just go so much further in terms of giving us the information to help your patients succeed.
Awesome. So is there any particular way that you need to submit the Topo Max to GelFlex?
Yeah, it's basically, whatever the specific export files, you just go through the export functions, and whether it's the Medmont, it's going to be .mxf. If it's through the Keratograph or Oculus platforms, it's going to be like a U12 files. So those are the most common ones that we're familiar with, but certainly there are other brands out there. And whether it's usually through email, if it's through GelFlex, just speak to the consultants. We put in the chat box as far as if you have any questions on specifics with your topographer, don't hesitate to reach out, and we can try to give you that information.
Awesome. Here's another question. How much do you change the parameters each time by the smallest step?
That's a great question. So it really depends. If you are, let's say, completely brand new to Euclid or Ortho-K fitting, I would start with the consultants. Don't hesitate to pick up the phone or send an email and sort of guide them through your thinking process. Nowadays, with modern technology, we all have cameras, we all have, on our phones, we have attachments that we can use on our slit lamps. If you can provide video or photos, that will really help us determine what the best increments in terms of change. And I certainly recommend, if we're still in the beginning stages of learning the process, to try to make fewer changes if possible. Don't try to make 2 or 3 changes all at once, because if there's a problem, it's certainly going to be more difficult to tease out what actually was the solution or what didn't work and what worked. But when you're making changes, there are going to be recommended increments that are the smallest that's going to be significant, right? So if it's too small, you may not be impacting the patient at all or the cornea at all. So you don't want to do too small of an increment. If it's too large, then it might cause problems in the other direction. So certainly you can reach out to both our teams and ask about those specific increments, because there's different levels to each curvature change, whether it's the base curve, reverse curve, alignment curves. They have different increment levels. So you want to do a few steps, but a sizable change where you're going to make a noticeable difference, but not too large where it's going to cause a problem in the other direction.
Great, thank you. So here's a specific question on a patient. What do you think of using Ortho-K for myopia control on a patient whose spectacle RX is for the right eye -6, -2 at axis 180, and for the left eye -5, -50 axis 180, but the topo shows 3 diopters of cylinder in both eyes. Even if the patient accepts only partial correction with over-the-top spectacles are too tricky and another myopia control method, should you use another myopia control method? So there's a good clinical question for you.
So there's a lot of layers to unwind with that question. So first of all, at least in the US, that would be considered off-label, and the person who's asking the question is exactly right. You may need to sort of really educate the patient and set expectations that we may be only able to achieve partial correction and to stay within what's approved in terms of our labeling. And so they may only have partial correction, which certainly with modern designs like using Euclid, with the Justin factor, which is that extra correction factor that we can put in, we can achieve very, very good vision for patients that are approaching these higher levels of myopia. But just it's one of those practice management tips, is just always set expectations. And if you over deliver, it's a great thing, but don't promise something that you can't deliver. In terms of the cylinder mismatch, I think I heard there was 2 diopters of spectacle cylinder and 3 diopters of corneal cylinder. That's pretty close to the case example that I reviewed today, where there was about a diopter of mismatch. And what that means is there's likely internal lenticular cylinder that may manifest once you start doing any kind of corneal GP. And this is not just Ortho-K, we're talking daily wear corneal GP, it could be even a scleral, where they may have residual lenticular cylinder that comes out. And that's where, again, you have to set expectations and tell the patient, hey, you're not a good candidate. There's an expectation you're not going to reach. In the US, we call it 20/20. I guess you would call it 6/6 in Australia. So there's a chance you're not going to reach that perfect visual acuity. And on top of that, you already have higher than the approved parameter range. So we may only be able to achieve partial correction. And so for children or kids, research has shown that that's still effective for slowing down their axial elongation, if you look at the research. For adults, if they're not interested in myopia management, but they're interested in refractive correction, they may still be perfectly acceptable. And given today's environment where they're constantly on digital devices, computers, screens, phones, they may be happy being a mild myope, maybe like a half diopter myope or 3/4 myope, because they can see their computer perfectly. And they may need to put some residual either glasses for driving at night, for example. So it's still possible, but again, I'm going to repeat the recommendation, which is talk to your consultants. They work on these cases, 20, 30 cases a day, each individual consultant, versus, you as a practitioner may only be working on a few of these cases a week. So they certainly have a lot of experience in that arena.
Great. Here's another question. Is it common for Ortho-K to suddenly stop working for a long-term Ortho-K wearer? For example, there's less flattening of the cornea despite the patient doing all the right things. There is no progression in myopia, stable axial length, and the lens is fitting well and in good condition.
So that's a fantastic question. So I can tell that practitioners probably dealt with that situation before, and I would say it happens. Statistically, I don't know what the how often it actually happens, but anecdotally, I hear that quite a bit from practitioners who do a lot of Ortho-K fitting. I don't know if there's any true science that really has studied why that would happen. Certainly, there can be a range of factors. Maybe there's some kind of change to the corneal biomechanics as we age. Maybe there's a change in the manufacturing process, which is sometimes really hard to tease out. And sometimes it just requires a refresh, meaning you wash the patient out, stop lens wear. You may need to try a different design. I've seen that happen many times before where we just can't find the reason why the patient's just not being effectively treated with Ortho-K, even though it apparently looks like no other parameters are changed. So I think that can happen. I don't know how common it is. And there's just a lot of different troubleshooting strategies. And so short answer is I don't know, but it does happen.
We've got several more questions coming in. When do you ask the patient to come back for the morning appointment?
Great question. So I have a lot of children who need to go to school, so we usually have them back as early as possible, and we make every accommodation so that we can allow them to be seen as early, let's say 8 a.m. But if for some reason there's any kind of conflict, I don't make it a huge point. It's okay if we need to make an exception. In those exceptions where they need to come in a little bit later in the day, I would say it's okay for them to remove the lenses because it's a little bit of a hassle to be going through, especially your first couple of days wearing the lenses while you're awake. So certainly it's not like a hard and fast rule. So if possible, try to get them in early. If it's not possible, I don't think it's the end of the world to have them remove the lenses, come in and just take a look, just as you would just have them put on the lens a little bit later. And I think that would be perfectly acceptable. And then a corollary to this point, just make sure that you get a mixture, as I showed in this webinar today, you get a mixture of afternoon and morning appointments. I find that there are so many things that happen that you want to see things in the afternoon just to see how the vision regresses, if at all. You want to see how they perform towards the end of the day. But at the same time, there are things that may go away, especially corneal findings in the late day that may be evident in the morning, as I showed through this example. So that's where I like to still get a mixture of appointment times, if possible, just to really, make sure I every stone turned and not miss anything.
Can you do still fit Ortho-K for adults? You kind of touched on the in the presentation.
Yeah, absolutely. So we have a ton of Ortho-K patients being fit as young as 6 years old, all the way up to we have a 7-year-old patient who's doing Ortho-K. She's doing a bit of monovision where we're undercorrecting one eye, and she loves it. So certainly adults can be a little bit trickier. A couple considerations. And well, first of all, we may know that Ortho-K was developed initially, decades ago for adults as an alternative to refractive surgery. So it was originally intended for adults, but the shift has been towards myopia management in children nowadays. But a couple pearls for adults. Again, David, you hit on it. I touched upon it on the presentation. You may want to go with larger optic zone sizes. That will usually cut down on the aberrations that adults are maybe more keen to deal with, especially because adults are the ones who may be driving at night, where they may be dealing with situations that impact their vision with the pupil size changes. And then keep in mind that adults, and I don't know if this is a fact, but anecdotally, maybe there's a difference in their corneal hysteresis or biomechanics. They may require quite a bit longer time period for corneal changes to take effect. So I've seen some cases where it can take up to 4 weeks for their cornea to make changes, whereas in children, it may take only a couple of days. So that's more anecdotal experience, but I hear that a lot from practitioners who've done a lot of adult Ortho-K as well. So those are the major considerations. And then obviously adults are driving. So depending on what the legal driving requirements are, you just want to make sure that they are safe to drive. If they need partial correction to get them through the day, that happens quite a bit more in adults than in children because they do have higher visual needs. So keep those considerations in mind when working with your adult patients. They just have slightly different needs, but ultimately they can be just as easy or just as complex depending on what their topography findings are, their corneal parameters, their refractive prescriptions, and everything.
Another great question. Do you wash out the patients prior to delivering new lenses with updated parameters?
That's a great question. I don't think it hurts if you wanted to have them spend, let's say, 2 nights off. If you're making a significant lens change, I think you could ask them to, take a few nights off, let their cornea sort of unmold slightly, and then they can start the new lenses. But personally, I don't think I often do that if I'm just making routine changes. It's only if I think that I'm making a big enough adjustment where perhaps the old decentered lens might cause problems, then I might suggest, hey, you're going to get this lens, and I'd like you to, spend the weekend, taking a little holiday from the lenses, and then restart in a couple days, and that way you might have a better chance of getting better results.
So you've sort of touched on this, but you can elaborate a little bit more. So won't reducing the optic zone size affect vision, particularly with larger pupils?
Absolutely. So yeah, it happens, and it's been a very hot topic. Optic zone sizes for the last 2 to 5 years. There's been a lot of research showing that it can improve slowing of axial elongation even further than using standard or larger optic zones. So, in my recommendation is that you want to find that balance. If it's too small, like the 5 mm, that could be very aggressive, and even children may not be able to tolerate the amount of aberrations, and children can have large pupils. So you might be getting just a lot of side effects for trying to get a lot of slowing of axial elongation versus the larger pupil sizes, the larger optic zones. Those won't have as much aberrations, but again, if you're following the scientific literature, it may not be as effective for slowing eye growth. So that's where, at least for Euclid, it's beautiful and nice that we have this ability to precisely adjust the optic zone size to the patient's needs. And so you can, start at 6.2, or you can go to 5.8, and you can adjust it or titrate it up or down with, in 0.2 mm increments. And that level of precision allows you to really, really make this specific for your patient, and not just use a standard size that may or may not be the right optic zone size for that patient. So there's a lot of nuance to this. It's certainly not a settled discussion. There's still a lot of research in this arena, but having that ability to adjust it will allow you to have the best balance of visual performance and slowing of eye growth, if that's what you're going for.
Yeah. And you hit on this too, but I'm going to ask the question from the audience. Is there a cutoff for the adult's age?
Yeah, good question. I did hit on it. Personally, I have a senior, or actually multiple adult patients who are in their 60s and 70s who heard about it through our marketing, and we were marketing it for the children in the office, and they're like, "Hey, what's this I hear I can see without glasses?" And we go, "Well, you can also do it as an adult. Here are the pros, here are the cons." And they were fully on board, and they are actually some of our happiest patients. So I don't think there's a cutoff. Certainly, if there's any mobility issues, if you don't trust them from a hygiene standpoint, those are other reasons that are unrelated to age typically. But I don't think there's anything that would prevent an adult to do Ortho-K. But just when they reach presbyopic age, you just have to be able to find the solution for how to solve their near issues on top of their distance correction.
And do you have a design for presbyopia?
Currently, we do not. That's a great question. So monovision, or slight undercorrection, or lowering the Jessen factor, which is that extra correction, is the name of the game currently with Euclid Designs.
Here's a really good question. When you change the optic zone size, do you have to modify the other parameters?
That's a great question. So in almost any kind of Ortho-K design, the answer is yes. Now, specifically, do you need to modify Euclid parameters? It's a maybe. Oftentimes, our consultants will guide you through that process. There may be slight modifications to sort of maintain the sag constant, and this is more of a lens design and lens engineering kind of question. But on Euclid's side, we usually will perform those kind of modifications for you. And if you have questions more specific to that, that may be a question or call to the consultant. But usually there are curvatures that are linked, so you cannot typically just isolate one curve change or one optic zone to different things. So let's just say specifically for optic zone width, there has to be, if you're going to maintain the same diameter, there has to be real estate that goes elsewhere, right? So it just depends on whether you're going up or down, and it changes those other parameters. But that's a little bit beyond today's discussion, but certainly call to your consultants will guide you through that process.
Yeah, I think you really nailed it. Rely on the Jeff consultants. I mean, they're here and they will guide that. Here's a question we get asked: what is the recommended replacement schedule?
That's a great question. So on average, I think most of our US practitioners, and at least how I recommend it, it is a 12-month replacement schedule to maintain the best, in my opinion, best sort of compliance, hygiene, and sort of visual performance. The best things that you can describe to your patients are, we're not doing a contact lens. This is not just something that you can get off the shelf. We are carefully and precisely changing the curvatures of your cornea or the eye, and this requires, we're changing the eye with micron precision level, and so small warpages and changes to the back surface of the lens that can significantly impact the performance, and that can lead us down a path towards improper acuity, corneal warpage, things like that. And this is my personal feeling. The patients that don't tend to follow up as closely, they may not also be doing other things compliantly. So from a hygiene perspective, there can be potentially more scratches, chips, damage to the lenses, things that might make us a little bit more susceptible for issues with Ortho-K. So just having the proper compliance, just like if they go to their dentist and they have their retainers, replaced routinely, that's one of those kind of analogies that they might understand a little bit better.
Wow, that was some great questions. We really appreciate that. We're running a little long now, so probably don't want to keep everybody too late. I did want to add that GelFlex is going to be at the OSO conference on the Gold Coast. Mark, is that tomorrow or and I know you want
the conference starts on Friday, so we'll be there if anyone has some follow-up questions and to talk about Ortho-K. And yeah, I just want to take this opportunity. I hope everyone enjoyed that webinar, and want to thank David and Jackson and the Euclid Corporation for organising it. And yeah, please, feedback's great from all of you who attended this evening. And if there's anything further you'd like to hear from us, then yeah, let us know and we'll try to organise something for you.
Thank you, Mark.
Yeah, thank you very much.